Hi, everyone. My name is Dimitri Tito, and I'm the chairperson of the AOGME Residents and Fellows Council. Welcome to our webinar on how to succeed on away and clinical rotations. Thank you for all of you for being present on the call. I also want to thank the resident speakers and the Council on Residency Placement that are present on the call. So I'm going to go ahead and pull up the PowerPoint here so you can take a look at what we have. There we go. And would you be able to put full mode on the PowerPoint and then move to the next slide? There we go. Thank you. So the AOGME Resident Fellows Council was first established in 2018 with the goal to develop future leaders in the osteopathic profession by creating a community and a forum for leaders just like you are, so that you'll be able to connect and collaborate. So the purpose of the Residents and Fellows Council is to provide not only a home for the residents, but also for fellows to come together and exchange ideas and network. It also serves as a platform for the residents and fellows to voice their ideas and concern about the graduate medical education. We're able to develop future leaders, we promote the well-being and continuum of the graduate medical education, and we also support advocacy and that address the needs of the medical trainees. So next, I would like to invite the speakers to actually introduce themselves. So for the speakers, thank you for being here. If you could share your name, where you're from, where you did your residency or your specialty, what year, and also your title. And then we'll go from there. So I would like to start with Linda.
Hello, everyone. My name is Linda Logan. I am a third-year pathology resident at UVM in Burlington, Vermont. I'm originally from Salt Lake City, Utah, but I trained in West Virginia with Dimitri and Allison, and I serve as vice chair on RFC.
Thank you, Linda. And then Maria.
Hi guys, my name is Maria. I'm a second year PGY2 at Christiana Care in Delaware doing emergency and internal medicine. I did med school at UNICOM in Maine, and I'm currently the policy committee chair on the Resident and Fellows Council.
Thank you, Maria. And then Mustafa, are you here? We'll go ahead and move to Jazz.
Hi, my name is Jajri Patel. I am a member of the Council on Residency Placement. I am Director of Career Development at the Alabama College of Osteopathic Medicine in Dothan, Alabama.
Thank you, Jazz. And then Lisa.
I'm Lisa Shelburne. I'm the Director of Career Services at Lincoln Memorial University DeBusk College of Osteopathic Medicine. I'm also a founding member of the Council on Residency Placement.
Thank you, Lisa. And then Holly.
Hi, I'm Holly Waters. I am an assistant professor of osteopathic principles and practice at MSU Florida in Clearwater. I did my residency in osteopathic neuromusculoskeletal medicine at St. Barnabas Hospital in the Bronx, graduating in 2019. And I also went to UNICOM in Maine previous to
that.
Woo.
Thank you. Thank you, Holly. And then Katie Harden.
Hello, everyone. My name is Katie Harden, and I am a residency placement coordinator with Kansas City University. I'm based in the Joplin, Missouri campus location. Prior to being at KCU, I was actually for 14 years the manager of medical education at a hospital where I oversaw all medical student rotation experiences.
Thank you, Katie. And I think Mustafa is back. Go ahead, Mustafa.
Yes, hello everyone. My name is Mustafa Bastri. I am a PGY2 at University of Wisconsin in Madison. I'm a radiation oncology resident, and I'm also a member of RFC, Residency Fellows Council, and I am excited to chat with you all.
And Dr. House?
Yeah, Ken Hiles. I'm the professor of family medicine at Kansas City University, and I'm also the campus dean on the Kansas City University Joplin campus, as well as the founding chair of the Council on Residency Placement.
Thank you, Dr. House. And I'm Dimitri. I'm a third-year internal medicine resident at the Western Michigan University School of Medicine in Kalamazoo, and I'm the chairperson of the Residents and Fellows Council. All right, so in the meantime, please feel free to enter your questions in the chat box, and we're gonna do our best to answer them. So I would like to move on and ask the speakers if you could provide one piece of advice or guidance on how students can best position themselves for success during their away rotations or clinical rotations. So what you do or what not to do. All right, I'm gonna just go in order here. I'm gonna start with Jazz.
Well, I think I have the easiest spots because I get to come up with the easiest ideas first. But I think the first part about going on an audition rotation is applying and getting those audition rotations. So, that means doing your research on which programs you're interested in and going through the whole application process and getting the documents required for that audition rotation.
Thank you, Jazz. And I agree with you. Just do your research and make sure you do the paperwork. So, all right. And then Lisa.
Well, I think my one biggest piece of advice is read more, as your preceptors always tell you. But from this view, read more means read the directions. Read the website, read what they put on social media, read everything so that when you ask them questions, you know what question to ask, how to frame it, and you don't ask them something that they just put on their website last week and you didn't see it. So read more.
There we go. So prepare yourself for the rotation essentially. So thank you, Lisa. And then Holly.
Thank you. So when I was doing my third year rotations, I found that what really set me up for each new specialty, regardless of how much background knowledge or interest I had in the specialty, was using like my favorite review resource. I think I used Online MedEd, for example, to prepare some of the base knowledge in very high yield clinical topics so that I would start day one really on my best foot forward, answering the attendings' questions, understanding kind of the major things that we were looking for. And from there, it built a really strong foundation so that throughout the rest of the month, I was able to learn even faster and really, essentially look good in the attending's eyes. And so it only took a few hours the weekend before, and it really set me up for success each month.
That's awesome. I think I also use Online MedEd for some of the topics I needed help with, but that's awesome. Yeah, thank you, Holly. And Katie Harden.
My advice would actually go for those students that are getting ready to start their third year, so your very first year of clinical rotations. So many of you are going into third year with a pretty good idea of what specialty you want to go into. And the advice I have is go into every single rotation with a very open mind. There is so much that you can learn and gain from each specialty experience that you'll be able to apply to the specialty that you end up going into. And so there's a lot to be gained that you sometimes, it's amazing how students will sometimes maybe not put forth quite the effort because it's a specialty they're not interested in or want nothing to do with. First of all, preceptors can tell. So even if it's a specialty you're not interested in, put forth the effort as if you are. Because you'll find you're going to gain so much more from it by taking that approach and having that kind of an attitude going into the experience. And I will say, there are so many of you that your minds will be blown by different rotation experiences and realize you love something more than you thought you ever would. So.
Yeah, I agree. I think the residents on the call can definitely testify for that. You could tell when students are not interested, I think, and I think the big thing will be being open-minded, and just like Katie Harden mentioned. be open to learn. All right. And then Maria.
So my advice is much less educational founded than everyone else's. Just be polite and introduce yourself to everyone. This applies to any rotation and basically, I guess, anywhere. But I'm surprised still. I'm only a second year resident, so I've only been like on the other side of this for like a year and a half. But it's always surprising to me when like a third year or somebody comes in and they just kind of sit in the corner and they're like overwhelmed and they don't know what to do and they don't like say anything to anyone. And we just like, we know they're coming and we know who they are. So we like go up to them and we like, at least in my program, we're like very friendly. But the ones that have come in and said like, hi, I don't know where I'm supposed to be, but I'm so-and-so, like, nice to meet you. It's just like puts a really good first impression on. So be comfortable being uncomfortable, because I still feel uncomfortable most of the time. And if you just get used to being uncomfortable, then the smile and introduce yourself to people will go a long way.
Thank you, Maria. I agree with you. And then Linda.
I guess I would just echo what Katie said is basically, if you go into the rotation and you discover that it's not really as much as you didn't like it as much as you thought, still act interested. Try not to lose interest in front of your preceptor. And, it's only 30 days usually, maybe a little bit more, but I would just say to try to put your best effort forward. It's going to be over soon if it's something you really dislike, but you don't want to be perceived as like the med student or the auditioning student who was too good for the rotation or didn't like the rotation, or you know what I'm trying to say.
Yeah, I agree. Just again, be open to learning, and the residents will know that you're not interested, or even the attendings will know. So thank you, Linda. And Mustafa?
Yeah, so I feel like a lot of what I prepared has already been addressed, but the three things that I prepared here were be a team player, show interest, and be kind and respectful of others. As a resident, I find having medical students helping with, things that seemingly not that important are incredibly helpful to advance, care forward and, help the team as a unit, like talking with, say, social work, bringing patients something that they want or need, and show interest. It's already been addressed, but, even if you're not interested in whatever the specialty is, you're there to learn. So try to, be interested in things, try to relate to whatever field you're interested in. I'm interested in oncology in general. And so when I went on OB, I was like, oh, let's see surgeon. That might be helpful for me to know. I didn't really like OB in general. Internal medicine, again, related to the workup of oncologic care and whatnot. And then lastly, be kind and respectful of others, because that's just a general great thing to be. Just be a nice person in general. It's easy to get along with you. It's easy for you to enjoy your time and be positive with your experiences. And overall, I think your clinical rotation will be much more meaningful if you approach everything with a positive attitude.
Yeah, thank you, Mustafa. You pretty much touched on exactly what I was going to say. Just be nice and respectful. I think as a medical student, it goes a long way if you take the time to actually also assist with the non-clinical stuff. Like, for example, if the nurse asks you to come and help reposition a patient, go ahead and do that. If a patient asks you for a cup of water, ask the nurse if that's okay, and then go ahead and and bring something for the patient. So essentially, if you can make yourself useful, that also goes a long way. Not only for the residents, but also for the nurses, for the PCA, just respecting everyone and being a good team player. And that really goes a long way in your rotation. So it's not always about how much you know, but also how to be a good team player. All right. And Dr. House.
It's really a disadvantage to be last doing this, right? I think, I really want to kind of expand a little bit on what Jazz talked about when it comes to the audition rotations and research, do a little research of the program and stuff. And Lisa said the same thing about read. But a very important thing is, whether we like to hear it or not, there's still, give or take, there's about 20% of the programs out there that are not really DO friendly. So before you decide to put the time and effort and potentially money into an audition rotation, take the time to look at their resident lists and see if that program has any DO residents there at all. And if they have like 4 or 5 programs, and maybe you want to do internal medicine, but check them all. And if there's no DOs there at all, then maybe that's not going to be your best bet to try to get, to get a rotation there, because you're definitely going to be against the, you're going to be behind the 8 ball trying to do that. So, that's a big part of the research is, especially as things get more and more competitive, you really want to, there's some very excellent many excellent programs out there that are DO friendly. So take the extra time to make sure that they are.
Yeah, that's awesome. I mean, that's a very good advice. I mean, that's when you need to ask, your medical school, the council on residency placement, or your upper seniors, where you should apply. So to find those DO friendly places. So yeah, thank you for sharing this. All right, so now I'd like to transition to Maria, so you could go through some of the top questions that were submitted by the students earlier. There we go. Actually, I'm going to have Katie Harden to go over the Council of Residency Placement and kind of what they do and how they could be beneficial for the students. And then we'll go ahead and move to Maria.
So the Council of Residency Placement is a collaboration of all of the osteopathic medical schools. There are representatives from all of the osteopathic medical schools, both faculty and staff. And honestly, everyone that's on the Council for Residency Placement have a vested interest in seeing students succeed in matching into residency programs. And so we work very collaboratively, brainstorming ways to improve medical education for students, including preparing you to be better physicians after medical school and after residency, and work on establishing tools and resources for students as well as the medical schools to equip you for success in getting into residency. And we also work quite a bit with a lot of the other councils, including like the RFC, to try to constantly brainstorm ways to improve your learning experiences and your path into residency.
Yeah, thank you, Katie Harden. All right. Maria, take it away. And then again, remember, you could enter your questions in the chat box and then we're going to be able to answer them. I think you're muted, Maria.
After so many years, you'd think. Sorry, that's embarrassing, guys. Okay, I'm gonna take this again. It's been a long week. So question number 1, what is proper etiquette for a letter of recommendation request? Let's see. Dr. Hiles, you want to start us off?
Yeah, I mean, I'll be happy to. I think the first and foremost is don't, when you're going to ask a preceptor for a letter, the first thing you want to make sure is that you have a good rapport with the preceptor, because a lot of times they'll say yes, and then either they don't follow through or you get a very, very generic letter. So, I think if you have a really good rapport with it and you've shown interest during the rotation, you were engaged in all the things that were talked about earlier. That'd be first and foremost. And the second thing I would say is, there are some preceptors that if they really like a student, they're going to ask the student if they want a letter of recommendation. Don't ever turn one down. You cannot have too many letters of recommendation. And as you're applying for residencies, you can pick and choose which letters you want to go to which program.
Expand on that a bit. When possible, ask your preceptor in person, face to face, if they'd be willing to write a letter. And one of the best ways for students to gauge the quality of a letter that a physician is going to write for them, in my opinion, is by asking them for some feedback on your performance. You know, I always told my students to make sure to ask for mid-rotation feedback to be able to improve their skills and performance through the rest of the rotation, but then towards the end of the rotation, ask for feedback. And I'm not just saying ask a yes and no question, but ask an open-ended question that's going to require them to give you feedback on what are you doing well and what are things that you need to be improving on. And honestly, you can gauge how highly they think of you and the kind of positive information they're going to include in a letter of recommendation based upon that verbal conversation that they have with you. If the entire conversation is extremely negative or just a lot of critiques of things that you need to really be focusing on, that's probably going to be a weaker letter of recommendation. But if they are praising you and really don't have a whole lot of criticism that's harsh, or, you know, you always want to be critiqued and be given opportunities to improve. That's always a necessity, in my opinion. But when a lot of their comments are very positive towards your strengths, that can say a lot about the content that they're going to have in the letter of recommendation. And after you have those kinds of conversations is the great time to follow up with requesting that letter of recommendation.
I think along with asking for the letter in person, also ask the letter writer what would they like to see to be able to write that letter. So we always recommend when you're asking for a chair of the medical school department letter, we always have a list that we recommend to send up front. You know, a CV, personal statement, a photo of yourself if you've just been on rotations and you're getting ready to leave so they know who it is. And go ahead and send them the information for ERIS so that they're not searching for different emails. They don't have to email you again and say, hey, can you send to me this? Making it as easy as you can make it on the letter writer is going to help.
And I actually have a don't for asking for a letter of recommendation. Don't ask on your first day of the rotation if you can get a letter of recommendation, and don't make it a statement, make it a question. Make sure you're asking for the letter because that is something that they are doing for you, and you shouldn't be demanding that from them.
Great advice. I will say very specifically to fourth years, or I guess rising fourth years applying EM, I'd ask for your letter sooner rather than later. It doesn't have to be on first day. I still agree with that advice. But if you want like a SLOE, which is the EM letter, most of the time, if you're rotating there, they expect that you will want one, but they like to have that confirmation up front from my experience. Linda or Dimitri, did you have any, or Mustafa? Cool. Alrighty.
A question answered asked in the chat that I think actually would be really good for the residents to maybe provide feedback that is tied to this question. And how do you increase your chances of getting one-on-one time with the attending when your interactions are 90% or more with the residents, so you can even ask for a letter?
So I would ask directly. I've been in multiple rotations, both as a medical student and then as a resident. And yes, while majority of the time in some institutions or capacities, you'll be interacting with residents, you still have that time with the attending, and you can ask them directly. Say, hey, I'm applying this specialty, and I would love to sit and chat with you a little bit about my application, or ways to improve my application, or overall match strategies, or something like that. And also, like mid-rotation, ask for feedback. It would be great if we can sit together and chat about ways that I can be better, more helpful, et cetera, et cetera. So directly asking, I think, goes a long way.
And there are many times that I put my former program director hat on. There are many times that the attending or the program director, whomever you're talking to, they will actually have the residents write the letter, and they will review it and sign it. So I understand yes, you do have to ask the faculty member, but the reality is they're going to go to the residents and say, okay, what do you think about this? Is this someone you could work with? And then the residents will actually write the letter. They'll look over it and sign it. I had like 15 years of doing that. So, and that's not necessarily a bad thing, because there's a better than average chance that the residents are going to write a more personal letter than the faculty member will anyway, because they spend so much more time with you.
Yeah, I agree. And the way I've done it before, as a third year, we have multiple students coming by, and they, if you just be honest, let the resident know, hey, I need more time with the attendings, and then we'll find a way to make that happen. Typically, I know the attending will come by during rounding time, like around 9 o'clock, and I'll make sure I get you exposed with the attending. For example, I'll give you like 1 or 2 patients. You could get the time to present, and then I'll make sure you have as much interactions with the attendings. I think that's one way. If you let the resident know, they can improve your chance of of interacting more with the attending.
Awesome. All righty, next question. What skills should we already be proficient in for each rotation? Good question. Dr. Waters, you want to take this one away?
I can certainly give it a stab. Of course, this is going to be very specialty dependent, but you definitely want to go into each rotation with at least kind of a baseline understanding of how to approach a patient case, do a workup, and present to your attending in the style that they like, because obviously like an internal medicine morning rounds are going to be very different case presentation style than an emergency medicine rotation, where they kind of want to for one, they'll want to go through like the whole history, HPI, chief complaint, admitting diagnosis, differential diagnosis, and basically everything. And then EM, they kind of want the in my experience, they want the bullet list, the major pertinent negatives, positives, and what you think is going to happen, and how you want the plan to proceed. And to understand that it's going to be a moving target no matter what, but getting the baseline of what is expected of you in terms of case presentation and coming up with a differential diagnosis for that specialty is going to be a really good starting off point in terms of seeming proficient or building your proficiency from day one.
One thing to add to that, I typically, even as a resident, when I have a new attending, I typically ask them, do you want the full spiel or do you want the 2-liner? And I found that very helpful, because sometimes, you're like very enthusiastic and like patient with X, Y, and Z comes in with, and that you can see like they're not listening. Mm-hmm. And other times, you give your 2-liners and they say, well, what about this and that? Traditionally, what I've seen as medical students, this is part of education for you to present what is relevant. And so typically the longer presentations are encouraged, but every attending is different. On EM, they'll probably ask you what you think is important in your 2-liners. But I would ask. And the other thing I personally like, at least as a resident, is to have the medical student know physical exam in whatever the area that they're rotating in. Personally, at least as a resident, I don't necessarily care about their assessment on plan. As a third-year medical student, maybe as a fourth year, I'll probably push them a little bit more. But as long as they know some basic questions to ask, things to look out for, how to do a proper exam, those are some of the things that are helpful for the team.
Absolutely. When you're giving your presentation, if you know the journalist term, don't bury the lead. Don't hide what you think is happening at the very, very tail end. Like, feel free to tailor your presentation to support whatever case you're trying to make is.
And another thing, as Dr. Waters said, a lot of it's going to depend on what rotation you're doing. So, for example, if you're about to start on a surgery rotation, know how to tie a knot. Know how to tie a surgical knot. You don't have to have suture. You can go get a roll of fishing line or thread's a little too skinny, but get some fishing line and practice on, you can practice tying on the leg of the chair or just anything that you can take it around. You don't have to necessarily know the needle side of it, but get very, very good and very quick at tying knots. And there you go. You'd be very surprised at how much that will impress some of the physicians, that they don't have to sit there and go from day one. And most of you probably have had it at some point during your first or second year. And if you forget, either go back into that and look at the video, or there's probably 50 videos on YouTube on how to tie all different types of surgical knots, and just take a few minutes and do that. That's probably one of the biggest complaints that we hear from preceptors is, they didn't even realize what would be expected of them on a surgery rotation. So, and that they always they have no idea how to tie a knot. They're not as concerned about, do you know how to judge the depth of a stitch or anything like that, but know the knot.
I can put in a little piece as well for pathology in particular, and probably not many of you are going into pathology, but if you want to, that's amazing. But in my field, professionalism is really the skill you need to show up with, because the amount of pathology that you learn in medical school isn't really that much. And so a rotation is going to seem hard and confusing anyways the whole time. So we don't expect you to show up and know every answer. But if you do show up and you're fun to work with, or you're professional and you try, in the sense of, we ask you like a really simple question and just kind of want to see how you answer it, we're not trying to scare you, we're just trying to teach you. So sometimes you really don't even need a skill other than just being professional and putting in an effort, even if it's kind of hard for you. And then you can take the things you learned that day and read a little bit about it later, and then try to build on what you learned.
And that be professional. That goes for every rotation you're on.
And I think the skills that you need for like your third year rotations versus your sub-Is are very different. As third years, exactly what Linda said, like most of the time we just expect you to kind of be present and be professional and be engaged, aside from like the surgical specialties that do like you to have some knot tying skills involved as well. But if you're going into sub-Is, that's something that I think they expect a higher level. They don't expect you to be able to like run an OR as an OBGYN or anything. I mean, I'm not in OBGYN residency. I don't think they do, but at least for EM and IM, which is the two fields that I did sub-Is in, IM, they want you to have, a pretty strong foundation for having a presentation. Like the presentation is really the key for IM. So being comfortable with that, you can talk to current residents, you can talk to fourth years who have already gone through the process to kind of get the nitty gritties on the specific specialty you're going into. And then for EM sub-Is, suturing is a pretty big deal when our med students want to suture. That's awesome. But also there's a couple really good podcasts specifically for EM. The EM clerkship podcasts in specific have a great series on how to ace your sub-I, how to get a good slow, and then some like quick facts. And they're each like 7-minute videos, and they're phenomenal. I listened to those before my sub-I, and I recommend them to any person interested in emergency medicine, but I'm sure other specialties have something similar. So asking people in that specialty if there's something like that you can use to kind of fine tune what you need to bring to a sub-I to make yourself a more prepared candidate to then be a more competitive applicant when you're going through that rotation.
Just a quick shout out to an app called Quick EM. I don't know if you know it, Maria, but it's a fantastic app that I loved as a medical student, in addition to UpToDate, in that whatever the chief complaint is, you put it in and it gives you the history, the physical that you need to do, the workup, the differential. If you at least just get the differential, you'll be superstar.
Yeah, Maria knows every app, so she probably knows.
Not everything. I'm sure there's tons of rad-onc apps that I don't know about. Alrighty. Next question we have here is coming soon. There we go. What are some of the specific qualities residency programs look for when choosing medical students? So probably a good question for some of our cord people. Anyone off the bat have anything?
I'm happy to field that one from the start. I'll get the easy low-hanging fruit for what we're looking for. So residency programs, one of the number one things that they are looking for is this somebody that I want to work with for the next 3 to 5 years? Can I see being in the trenches with them? When it's, night float or whatever kind of whatever the worst part of the job is, do I want them by my side? And a huge thing that I hear from program directors and attendings is this student teachable? Can I teach them what I think they need to know in order to make them a successful physician? Because you don't have to go into residency being perfect. And some specialties you're not going to have a huge amount of baseline knowledge when you first start out because it's so specialized, but they want to know, can they get you to the point where they feel comfortable with you graduating as an independent practicing physician? And those are two of the qualities that I hear as being some of the most important that program directors look for in potential residents.
I'll try to condense it to 3 words: honesty, integrity, and communication. If you've got those 3 things, when I was a residency director, I could teach the knowledge. I can't teach the personality. I can't teach your integrity. I can't, I guess lumped all into the professionalism. And I know we sound like a broken record, but I promise you that is the number one complaint that we hear at the medical schools regarding the students. And that's probably the number one reason I end up having to meet with students. It's not their grades, it's their actions. So those 3 things will carry you far in medicine.
So as a third, go ahead.
Go ahead, Dimitri.
Oh, okay. Then I'll let you go next. So as a 3rd-year resident, we also get to interview applicants for residency. So the big thing is also whether you get along with the residents. So I'll give you 2 examples. Recently, there was a student that would interrupt the resident in front of the patient. That's one example. So, and then he would do that each time. That's something not to do. And another example would be a student that would just, he would just disappear during rounding. So he would be gone for hours without letting anyone know. So I think once you start your clinical rotation, just also make sure that you get along with the residents, and you respect everyone. And then just like Dr. Waters and Dr. House mentioned, integrity and be honest and being professional. Go ahead, Jeff.
Yeah, I was going to piggyback right off of that, working with the residents, he said, but teamwork, I think, is important. As a pharmacist, I know that I value that in physicians as well, and working with nurses. I think you're working with all of the healthcare team, and you have to respect their knowledge and their title and what they bring to the table too, because everybody has a different perspective, but in the end goal, we're all there for the patient. And so working together, I think, is really important.
The other thing residents appreciate or look for in medical students when they're asked if they think that medical student should come here for a residency is how well did they fit into the environment of the hospital and of the team. So echoing what Jazz is saying, if you're a team player, did you fit in with all of the residents? Could the residents see themselves being around you for many, many hours and for long periods of time? So even if you do really well, but you struggle with fitting in, I'm not trying to say that in a negative way, but if you just don't really, I don't know, trying to think of a nice way to put it, but if it just doesn't seem like you all get along, it might not be the place for you. So there's a specific place for each medical student to match and a specific environment. And you'll experience that when you interview. You'll kind of get a feel for kind of where you want to be.
Awesome. All great answers. All righty. Next question. How should we handle not being good at something and being put under pressure in the moment of answering? So I'm taking that as like in a pimping type environment.
Number one, be honest. If you don't know, just don't say, I don't know. Say, I'm not really sure of the answer, but I will research it and come back with an answer tomorrow.
I had one of his perspective when it came to a student that didn't know the answer. He was like, I realize you may not know the full answer, but I guarantee you, you know a sliver of it. Share what you do know. And he said, it's amazing how you can talk through the components that you do know and remember. And before you know it, the rest comes together. And he goes, at least share the component that you can recall, because that's at least something. He's like, it shows me that you at least have been reading or you've been studying on this subject and on my specialty, and that you've at least been able to bring something to answer the question, even if it's not the full answer. He goes, something is better than nothing. And you and I can talk through, and I can prompt you with additional questions to pull the rest of the answer out of you, because it's probably in there. And so that's a great thing to do, is give them what you do remember, talk through it with your preceptor, and you may actually recall the rest of it.
When I have students rotating with me and I ask them questions, I will sometimes, I admit it, ask them questions that I don't expect them to have a good answer to at all. And what I'm trying to do is see what their thought process is. I want to see how they think. I want to challenge them to kind of think outside the box, and then show me what steps they do put together to get some kind of answer. And so that I know how to work with them, how to teach them to explore further. I don't expect students to, read my mind every single time I ask a question. And I don't think that would be very educationally beneficial for them. I want to start a discussion. And so what I have, sometimes I have students, especially early on, who, when I ask a question and they don't immediately know the answer to, they freeze. And so what we work on together is, kind of calming down the anxiety regarding a question that they don't know the answer to, being like, let's work through it step by step, like Katie Harden was saying, and like a number of people have been saying, tell me what you do know, tell me kind of your thought process in this, and let's see where we go. A lot of it is related to just that stress of getting something wrong and looking dumb. But, remember, in medical education, you are the learner. You are meant to be finding the questions that you don't know the answers to, so that you can later have more answers to questions that you never even thought of before.
Awesome. Alrighty, I think we're ready for the next question. What are common mistakes students make on rotations, and how can students avoid them? Let's see.
I'll go first. I think one of the common mistakes a student might make on a rotation is not going home and reading every night. I know rotations are tiring and maybe you're on audition, but you really need to go home and read every night about what your patient's conditions that they have, or if you're in the OR tomorrow, what kind of surgeries they're doing, and maybe, refreshing on your anatomy for those procedures. So prepping what you learned that day and prepping for the next day, I think, are really important, because in the end, it'll help you build up your clinical reasoning and your ability and be able to answer some of those tougher questions your preceptors may ask you.
I personally was just going to say, oh, sorry, Katie, you were going to say something. Go ahead.
I was just going to piggyback on what Jazz was saying. And one of the biggest complaints I always got from preceptors is students' lack of preparedness for the day. And you have access to the EMR for a reason. So study your patients, look up your patients in advance, read their HMPs, If it's a surgery you haven't done before, watch the videos that are available on YouTube and other resources to do your homework and be prepared. Know the anatomy for that case. There's just so many things that you can do to make your day a little bit more prepared. If there's a diagnosis you're not familiar with of a patient you're going to see tomorrow in the clinic, read up on it. If there's a medication you're not very familiar with, read up on it. You know, like Jazz said, you know, read and Lisa said, read. Well, you've got to prepare for every single patient, and you have access to their records. You know which patients are on the schedule for OR. You know which patients you're going to be seeing in clinic. You know which patients have been admitted to your preceptor for tomorrow already that are there. So spend your evenings in looking that kind of information up.
Yeah, completely agree with that. What I was going to add is, you know, you've functioned as part of a team. And so one thing that I have been, or I've noticed, is that sometimes, you know, in an attempt to look exceptional as a medical student, unfortunately, inevitably, you may be putting others down. And that's not healthy for team dynamic overall, and doesn't necessarily look good that you're really that, you know, prepared. You know, have that kind of teamwork, you know, be a team player. You know, the goal isn't necessarily that you get every single question right, or you jump in and answer all the questions. The goal really is for you to grow. And in that vein, whatever your baseline is, that's great. But then I want to see that progression through the rotation. What did you actually learn? If you know everything, you know, you probably should not be in that rotation. But chances are you don't, and that's fine. That's why you're in the rotation. And so, you know, be humble, be kind to others, be a team player. And then I lost my train of thought, but
I would say be punctual. I've never seen students lose more pointless respect, or like have a more pointless loss of respect from their teams than those that show up late. And, you know, 5 minutes could mean missing all of rounds because you can't find the team if they've already left. And professionalism in general, like many were sharing.
I think one of the biggest things is to expect the unexpected. So a lot of students say, stash some crackers in your pocket, stash a change of clothes in your car, because you don't know what might get on your clothes. You don't know when you may get hungry. So always be prepared for the unexpected, because you don't know what's going to happen. They don't expect you to know everything, but just like everybody said, they want you to be a team player and be adaptable, be flexible.
Speaking to the teamwork that's kind of been thematically thrown in here, also like know your ability to work with the resident team. We've had some great students who are like punctual and they're on time, but they also like know how they can be an asset to the team, and they are able to kind of help with discharge summaries on the medicine floors, or they're able to like be an asset to the team and just kind of move patient care forward. And then we've had some medical students who like will come into the resident workspace and take all of the residents' like papers off of the computer the resident was just writing a note out when they go to the bathroom, and put them on the floor, and then take over that resident's computer and sit there to look up patient charts for like next week. And that hasn't been looked too positively on. So just know how you can be helpful on the resident and the medicine or whichever team, and know how things can, what things can maybe be looked less positively upon.
And, you know, another thing is be engaged, you know, and I'll give you an example of what never to do. And this happened within the last year, because I get a phone call from a surgeon on what do I do about this. And the student, there was an emergency surgery come in through the emergency or through the ER, and they were taking him to surgery at like, I don't know, they were scrubbing in about 4:45. And the surgeon happened to look at the student who's just standing there and said, are you going to come over here and scrub in? The response was, no, my shift's over at 5 o'clock. So the surgeon called me and he said, "What do I do with him?" I said, "Well, what's your gut feeling?" He says, "Well, I want to fail him." I'm like, "Then do it." So stay engaged. If you're asked to do something, do it. Contrary to where residents have work hours, students do not. So, there's, and don't think for a minute that every program, every residency program has a group of program directors. They have their own organization, and don't think things like that don't get shared. So be mindful, be engaged. Now, if you did have something that evening that you already knew about, then mention it during the day. Mention it first thing in the morning, but don't say, "I'm leaving at 4:30 because I have this." Say, I've got a conflict occurring this evening. Would there be a problem if I left a little bit early? So just put it in the form of a question. Don't tell them what you're going to do. Ask them if it's okay with them to do something, and don't make it a habit of that either. Once a rotation, maybe twice if you're really pushing it, but just, you can put up with anything for a month.
Awesome. All righty. I think we have one more question on this. Yes. All righty. How do we make our rotations more engaging if our preceptor is adamant on more of a shadowing approach? It's a good question. Anyone in particular?
So when I had it as a student personally, it was unfortunate and disappointing. And I was one-on-one with the attending. You typically see that sometimes in a consultant type rotation. And the knowledge and the depth of knowledge that you need to know is a little bit too specific. And sometimes it just takes a long time for the attending to, unfortunately, be with the student and teach and whatnot. But I use that opportunity to basically learn about, I picked a patient a day and I learned about whatever that thing is. And then I had specific pointed questions to the attending. And, over time, the attending actually enjoyed discussing patients with me, because you read about them and you bring some questions, and, you don't know the material, you don't know the case, and you have those questions without preconceived notions. And so a lot of times those questions can be thought-provoking and really helps the attending themselves think about the subject. And so it was an educational experience for me. A lot of times they typically give good feedback and good evaluation. So in the grand scheme of things, it's not the worst thing. It is frustrating, unfortunately. If you're interested in this particular specialty, make a point of it. Who knows, maybe they will take interest and invest more time. And I would also feed that back into the school. Just let them know, by the way, this happened. It was not quite an educational experience that I thought. Who knows, maybe it will be helpful.
I will say I've also had some preceptors that have intentionally not engage the student a lot because they want to see if the student will take initiative. And so I do think you're going to also have those preceptors that want to see if you're going to step up. Are you going to speak up for yourself, be assertive in a professional manner to ask to do things? And so some preceptors, they just won't let you do it until you ask. And so don't ever be afraid to take that initiative to ask if you can participate in things, especially if you've already done certain procedures with other preceptors. Share that with them and ask if you can assist them with that procedure, or, ask if you can go round on the patient ahead of them. And so don't be afraid to ask. They can always, worst case scenario, they say no. They may be that preceptor that's waiting to see what kind of student you're going to be, and if you're going to take charge and take initiative.
Yeah, I agree with Katie Harden and Mustafa. Even as a resident, some preceptors want me to shadow. And the way I would do it, I would go in the room with the preceptor and I put my gloves on. If he's putting his gloves on and he's about to do a procedure or looking at a rash, I'll pretty much be proactive and take the initiative Again, as a preceptor, if it's okay, if you go ahead and see the patient for a couple of minutes and before he goes in, those are different things you could ask a preceptor, but it's going to happen and again. Some preceptors just want you to, to shadow, and they expect you to still learn and be open-minded and ask questions.
Awesome. Anyone else have anything hard hitting on this? Alrighty, I think that puts us into our live Q&A. There's some questions that have been going on in the chat. I know Katie marked one to be answered live, so we can go ahead and kick off and start with that one if we want.
So the question that was asked in the chat was, and this is something unfortunately happens way more often than we wish, but yes, there are preceptors that sometimes ask you as a student to write your own letter of recommendation. So the question is, how do I approach this? What do I do? So first of all, know that you're one of many students that are asked to write their own letter of recommendation. And as much as we don't like it, see it as a gift. You get to have a little bit of control over the content of your letter, and write some strong qualities about yourself. And AACOM does have a resource page. We're going to see if we can get it shared with you in the chat. That resource page is intended for preceptors, but really you as a student, I've had students, I've shared it with them. It provides some guidance for how to write letters of recommendation and some of the tips and tools that you can use. But go ahead and do it, share it with the preceptor. Keep in mind, the preceptor can always edit it. They're wanting you to start with something. You're not the one that's going to be uploading that letter to ARIS. They are still doing the final upload. So whatever you put in there, they have the ability to modify and change and align with what their perception and perspective is anyways, before they upload it into ARIS or it gets shared with your school to be uploaded to VSLO.
Awesome.
Go ahead, Maria. Thank you.
Perfect. Okay, we have time for one more quick question that I think Dr. Hiles is going to answer live for us. It was in the chat. It says, how do you know when to go home? What if they forget to send you home?
The first thing I would do is I would recommend that on your first day of rotation, try to, ask them what their guidelines are, and a lot of it's going to depend on what the rotation is. Is it a clinic rotation? That's usually easier because when the physician leaves and the staff's getting ready to go home, it's time to go. But if it's a hospital rotation, ask them what the expectations are. What time do you need to be in for rounds in the morning? Do you want me to round on your patients before you get here? Do you want me to do afternoon rounds? And, again, it goes back to having open communication with them on the front end, because a lot of times they're not going to say, okay, you can go home now. But if you have the expectation set early, and also know if they're, probably not as much now, because with the hospital, whenever I was doing rotations, we had them, they would be on call at night or what have you. But now it's, you have the hospitalist and the nocturnist. So, there's a little bit of a difference there, but just ask them what the expectations are. Ask them, what they want you to do and what they don't want you to do, because everyone's going to be a little bit different. I can tell you, if it's a surgery rotation, you probably ought to be there by about 5:30 in the morning. And if they're not on call, and they're not going to have an emergency come in, then you're probably going to be able to get done, within an hour or two after your cases are done, and they do post-op rounds or what have you. But just ask them.
Yeah, thank you, Dr. House. Just wonderful advice here. So we're going to go ahead and wrap up the webinar. And before we do, I'm going to ask the panel to give the students one last piece of advice as they go on and start their clinical and away rotations. So I'm just going to go in order here, starting from the back. You go ahead and start with Maria.
Oh, in the back. That's exciting. Okay. My advice is to have fun. I think third and fourth year rotations can be very stressful. There's a lot going on. There's a lot of pressure, a lot of things on your plate, but Remember how hard you worked to get where you are. You're finally out of the classroom. You're finally in the hospitals doing the rotations. No one really knows what they're doing, not even most of the residents. I sure don't know what I'm doing most of the time. I mean, I'm learning more now, but my point being, try to enjoy it, try to embrace it, and it'll show, and it'll be easier then for you to be engaged and be positive and be professional and be proud of yourself.
Thank you, Maria. And Mustafa?
I was going to say exactly what Maria said, trying to have fun. I mean, I know we're talking about, you got to do this, you should not be doing that, but it is a lot of fun. You're learning a ton, you're growing a ton as a student, and maturing into the position. And some of the things that you're going to pick up during rotations are some of the things that you're probably going to keep as a practicing physician. And so I would try to have fun, try to enjoy it, be you, be real, and see if you would vibe in whatever environment that you're in, and that would feed into the residency process moving forward.
Thank you, Mustafa.
Feel free to reach out to us.
Katie?
Make sure to take care of yourself. Make sure that you're taking time to breathe. Third and fourth year can be extremely taxing, extremely stressful. I think you'll find fourth year probably more so than third year. So make sure that you're taking care of you. You're taking time to rest. You're taking time to do things outside of your education, things that you enjoy doing, because you'll find it's a great kind of rejuvenation and reset for you as you go back into your clinical experiences each day and each week.
Thank you, Katie. And Holly?
There's been so much good advice. So I think my advice is going to be bring extra pens and a bottle of water if you're allowed to have one on the floors.
Thank you. Right on. Lisa, go ahead.
Well, my biggest advice is utilize your resources. Whatever resources your school, AACOM, the Residents and Fellows Council, utilize all those resources. At the end of the day, bring it back home to your advisors, your residency advisors, your rotations advisors, your school or mentors. Be very careful about reading sources that you really think is a resident and it's actually an online dog groomer in their mama's basement, and they're just causing trouble on the internet. So bring it back to the people you pay to advise you, because your success is our success. So trust the process.
Thank you, Lisa. And then Jazz.
I would say smile to everybody, the patient, the nurses, the residents. It'll go a long way to opening the conversations.
Yeah, thank you, Jazz. And then I'm going to time in, just again, smile and then bring a lot of pens, especially for your inpatient rotations. If you don't write it, you're going to forget it. So just always write it down. All right. And then Dr. House, there we go. Yeah, you last again.
I know you did that on purpose, Dimitri. I'll remember that. I think, I agree with everything that everyone said. The only other thing I would add is, depending on what rotation you're in, if you're on surgery, read ahead on what surgeries you're going to be doing the next day. Go in prepared. If you were on medicine, if there was a patient admitted that afternoon, read up on what they were admitted for, so that when you do get those questions, you don't have to go, oh, geez, I'm not sure, I'll look it up. Be proactive. Be prepared. And along with what everyone else said, I think if the more you're prepared, the better you're going to look. I see Maria shaking her head yes, so I think she's.
Yeah. I think everyone agree. Thank you for your wisdom. Yeah, we love your wisdom, Dr. House. All right. Well, thank you everyone for your time. Again, this session is recorded and it will be available for you. Wonderful questions. Visit our website at www.aacom.org/RFC. You can also follow us on social media. And you all have a good evening.